So, this is the first key slide. It shows what is safe apnea time.
Sir, after adequate pre-oxygenation, the time we take after stopping the pre-oxygenation and proceeding for the scopy, sir. 7 to 10 minutes in inclusive vulnerable individuals, depending on the FRC reserve.
This is the duration. What is the indicator that your patient cannot tolerate apnea anymore? Supposing you are starting with a SpO2 of 98, 99 in room air, you are giving 100% oxygen for 3 minutes as a pre-medication, pre-oxygenation. It goes to 100 and maintains. Then you give the induction agent, you give the paralyzing agent, and patient stops breathing. You are taking away your mask, you are putting your laryngoscope, you are having some difficulty visualizing the cause, you take time. What will happen to the saturation during that time?
Drop in saturation.
It will start decreasing, isn't it? So that is the idea or the guideline for you to know that patient is not tolerating the apnea anymore. Okay. So safe apnea time is defined as apnea time in minutes until oxygen saturation is maintained above 95%. Okay. Once it starts decreasing below 95%, that means the apnea time is not anymore safe. Okay. That is the indicator. What are the techniques of providing apneic anesthesia?
Deep breathing.
High flow nasal oxygenation
And
We can use thrives.
there are several options for you. So can you provide it
sir.
with high flow oxygen supplementation, mask ventilation, tube in route ventilation, jet ventilation, and thrive. Okay, these are all the methods. Which surgeries require apneic oxygenation or anesthesia?
Foreign body.
Bronchoscopy.
Anything to
Foreign
be done
body
with
removal.
trachea and bronchi. So these are all the microlaryngeal surgery, bronchoscopy, rigid bronchoscopy, serial tracheal foreign body removal, tracheal stent removal, vocal cord nodule excision. All these mostly upper airway surgeries. Okay, those are the ones which require a patient to be apneic. You don't want the patient to breathe and vocal cords to move when you are doing a vocal cord nodule resection. Usually, when you are doing a bronchoscopy or a flexible fibroscopy examination, you don't want the patient to be breathing. So, what is the mechanism of gas exchange in thrive?
Cardiogenic oscillations.
Cardiogenic oscillation. Very good. Right. Oxygenation maintained by continuous high flow, increasing alveolar oxygen content, facilitate oxygen exchange due to a concentration gradient. Okay, so there is a continuous. What is the flow rate that you require for thrive? How
40
many
to
liters
70
of oxygen?
liters.
40 to 70 liters.
Okay, so carbon dioxide clearance is by microventilation and cardiogenic oscillation. So there are two components in thrive. One is maintaining oxygenation, and because that is why it is called, what is the expansion for this acronym?
Transnasal humidified rapid insufflatory ventilatory exchange.
Ventilatory exchange. So this ventilatory exchange means you should have oxygenation, at the same time you should have removal of carbon dioxide also. Whereas in your normal apneic oxygenation, you will have good oxygenation, but carbon dioxide will start accumulating. It will not go up. But the advantage of thrive is it will help in removing the carbon dioxide also. So the oxygenation is taking place because of the high flow of oxygen that is coming there, maintaining a gradient between the airway and the blood. Whereas the carbon dioxide removal is due to microventilation via cardiogenic oscillation and gas mixing in the anatomical dead space with a high flow. Then continuous positive airway pressure maintains airway patency, prevents airway collapse, and washed out dead space, resulting in improved gas exchange and safe apnea time. That is how the drive helps. Three things that you have to write for that. What are the complications due to thrive? How are they managed?
Carbon dioxide accumulation.
Carbon dioxide accumulation will happen after some time, and not like your other high flow oxygen.
Polytrauma, sir.
Gastric distension, potential aspiration of blood and secretions, which are prevented by supine positioning with head down tilt and extension. Meticulous hemophilia. That is, if you are using thrive during surgery, these are the problems. And hemostasis should be, and you can do frequent suctioning also. And nasal discomfort due to high flows may occur, but the risk is minimal due to warm humidified oxygen through soft and wide bore cannula. And carbon dioxide clearance after some time will not be adequate for prolonged period. Therefore, frequent measurement and restriction of apnea time are advisable using thrive for surgical anesthesia. Now you are seeing a drug being displayed. What is shown here and what are the other preparations of this drug available?
Inotrope.
Inotrope. What is shown here?
Dobutamine
now,
injections are displayed here, sir. Dobutamine injection.
Ampoules.
Liquid form. Okay, this is the injection dobutamine hydrochloride available in liquid form in a 5 ml ampule. Okay? So this is a pack of 5 ampules. And each ml contains 50 milligram of the drug with a total of 250 milligram. So one ampule is 5 ml. So each ml is 50 milligram. So total of 250 milligram. Is it available only as a liquid form? That is the reason for the second question. What other preparations are available? Do any one of you seen other preparations?
No, sir. Only
Marketed as lyophilized powder to be reconstituted before use. You can see Abbott company is producing the same drug 250 ml vial for IV infusion after dilution at least with 50 ml. Okay, of lyophilized powder form is also available. What class of drug is dobutamine? What are its pharmacokinetics and pharmacodynamics?
An inotrope, sir.
It's an inotrope. Does not have chronotropic action.
It has
The
chronotropic action.
pharmacological agent with both inotropic and chronotropic effects. Okay. And what is the onset time? 1 to 2 minutes. Very, very quick onset. What is the half-life? Why dopamine, dobutamine, all these things are being given as an infusion instead of in the intermittent bolus doses or triple bolus dose?
Short half-life.
Very, very short half-life. Okay, so that is the reason why any drug with a very short half-life, you have to give it as a continuous infusion for sustained effect. So plasma half-life of dobutamine is approximately 2 minutes, and that is the reason it is used as an infusion. The same thing applies to dopamine also. So all drugs which you inotropes which you give as an infusion, remember all of them have a very, very short half-life, and it is excreted. Kinetics means administration, that is absorption, distribution, metabolism, and elimination. So it is excreted in urine after metabolism by catechol O methylation. Just like how your other catecholamines are metabolized in your body, this is also belonging to that group. So on conjugation to dobutamine or 3-O-methyl-dobutamine. And inotropic effects on the myocardium. This is pharmacodynamics, mainly acting on the beta-1 receptors. So it is a beta agonist. It has some beta-2 activity which contributes to the reduction of SVR and some alpha-1 activity, but it is comparatively very less to beta-2 activity. So when a drug has got a good beta-1 effect and beta-2 effect, producing a good contractility and reducing the SVR, what do you call the drug? Improving the contractility, that is inotropic effect, and reducing the systemic vascular resistance. If both these characters are present in the drug, what is the drug called?
Inodilator, sir.
Inodilator, fantastic. That is the correct answer. What is the indication and dose of dobutamine rather? Where do you use it?
In
Cardiac,
cardiogenic
cardiogenic shock.
Cardiogenic shock is an off-label use, but acute cardiac failure. It is indicated for a short-term use. It is not a drug to be used for long-term like your Norend and dopamine. It is a short-term use drug for decreased contractility due to heart failure or cardiac procedure resulting in cardiac decompensation. What is the dose?
5 to
5 to
20
20 mics per
mics
kg
per
per
kg
minute.
per minute.
That's a range of dose. You can do it from low dose to high dose. Okay, so there is always a range of dose. So lower doses is 2.5 to 5 mic per kg per minute. Higher doses are 5 to 20 microgram per kg per minute, depending on patient's response. Now we talked about dobutamine stress test some time ago when we discussed about the peripheral vascular disease patient. So how do you use it for dobutamine stress test?
Sir,
We inject the drug.
Inject the drug.
To achieve a maximum heart rate.
heart rate at which the ECG changes
Target heart rate. How do you fix the target heart rate?
220 minus age.
Very good. What is that called?
Bruce protocol.
Bruce protocol. Fantastic. Dobutamine infusion is administered intravenously at a starting dose of usually 5 microgram per kg per minute. Then the dose is increased every 3 minutes until the patient reaches their target heart rate, which is determined by their age and physical condition. Maximum dose you can go up to is 40 to 50 microgram per kg per minute. And during that time, you do a echo study and see whether the patient develops any regional wall motion abnormality or other problems or like arrhythmias. And it will be equivalent to physical stress test which you do in the treadmill or the cycle. What is shown here?
Cardiac action
Ventricular action potential, sir.
But particular myocyte action potential. Action potential is the cardiac myocyte. Okay. What is this? How is it different from pacemaker cell action potential?
Phases, a number of phases.
It
Many
doesn't have the
channels are
plateau
there.
phase.
Refractory period is no refractory period in case of pacemaker cells, sir.
Number of phases are there is phase 1 and 2 are absent in pacemaker cells. Okay. What is phase 1? This is the phase 1 early
Sodium
repolarization and
influx.
plateau. They are not there. It will be just like that, like an inverted U. Okay. So these two phases are not there. Cardiac myocytes have a resting phase with a membrane potential of minus 90, while pacemaker cells do not have a stable resting potential. That is another difference. Okay. Here you can see the resting potential is almost 85 or 90. This is not present for because they have to spontaneously, here there is a simulation coming and doing all this asymptotic. Whereas for a pacemaker, they have their spontaneous stimulation. Now this is a formula that is being shown here. What is this? The plasma light with the sodium bicarbonate, mannitol, magnesium,
Cardioplegic solutions.
the cardioplegic solution formed by what is Dr. Bell-Nido formula. Okay, and what is ischemic preconditioning?
We expose the myocardium to insults, short intervals of ischemic insults, so that they can tolerate it better.
But better for a longer period
Longer
of
time.
time. Okay, right. It's an adaptive phenomena whereby heart becomes more tolerant to prolonged period of ischemia if exposed to brief periods of coronary occlusion. That's why they say patients who develop angina pectoris, who suffer from small ischemia, they have a better outcome after they develop or lesser incidence of infarction than patients who develop sudden infarction all of a sudden. Okay. So what is the clinical relevance of the IPC? This is the answer. Patients who develop angina have a better prognosis and smaller infarcts, less severe cardiogenic shock. Patients who undergo PCI after were suffering from ischemic precondition have enhanced tolerance to ischemia. The first balloon inflation exceeds 60 to 90 seconds. And third one is intermittent cross clamping followed by 2 minutes of reperfusion before 10-minute period of global ischemia causes less troponin release in these patients who have ischemic precondition. Can you identify the black oval part attached to the EP tube? This one.
Anaconda, sir.
Anaconda, yes. This is the anaconda anesthesia device. What prompted the idea of anaconda device?
Use of inhalation in
ICU.
ICUs. Inhalational in ICU, sir.
No, that is the use of that for making the patient quiet during mechanical ventilation. But what prompted the idea of anaconda?
A vaporizer inside the circuit type of.
It is basically a modification of HME filter. And where is it used? Is it used? That is the answer for your this thing. We may need for sedation for patients on ICU, ventilator in ICU. How does it work and conserve anesthetic agent?
So it has got carbon filters, proximal and distal part.
So contains a miniature porous evaporator rod that converts the volatile agent into vapor. A liquid anesthetic agent is pumped into the evaporator from a syringe infusion pump. And the anesthetic vapor formed in the evaporator is picked up by the air oxygen mixture from the ventilator and delivered to the patient during inspiration. 90% of the expired vapor is absorbed by the carbon layer and recycled during next inspiration, thereby conserving the agent. So this is the mechanism how it works. This is the reabsorption by the carbon layer and recycle. That is how the agent conservation is done. What agents are used at what infusion rate?
Sevoflurane, sir.
Sevoflurane is commonly used, but here the color you can see
Isoflurane.
Isoflurane.
Isoflurane, sevoflurane are used at the rate of 5 to 10 ml per hour initially, which can be reduced later to 2 to 6 ml per hour. What is Hagen-Poiseuille equation? Although it is written as Poiseuille, it is pronounced as Poiseuille. It's a French name. So, Hagen-Poiseuille equation, and where is it applied?
It is used to determine. It is used in laminar flow, which is nothing but it is directly proportional to the pressure and the fourth power of the radius, inversely proportional to the viscosity and the length of the tube through which the liquid or the gas passes.
The equation which defines a flow through a tube, taking into consideration the length, the radius, and the of the tube and the viscosity of the fluids. So three things that are taken into consideration are: one is the length and radius of the tube through which the water or fluid is flowing, any gas or anything is flowing, and the viscosity of the fluid that is flowing. It is applicable only to Newtonian fluids undergoing laminar flow. So it is not applicable to non-Newtonian fluids or
Turbulent flow.
turbulent flow. What is the formula?
Flow is equal to delta P pi r to the power of 4 by 8 neta L.
Excellent, very good. The Q is equal to pi PR4 8 eta L. So Q is the flow in liters per second, P is the pressure in pascals, R is the radius, L is the length, N is viscosity. It is N is not it is not N, it is actually eta, which is a Greek numeral. And Pascal is a second in SI unit. Pascal per second is a SI unit number. So what do you understand from this equation?
As the radius increases, the flow through the laminar flow increases.
So flow of a fluid through the tube increases with increase in pressure and increase in radius of the tube. Okay? That is what it is. And flow reduces with the viscosity and the length of the tube are more. That is the simple thing that you can understand. Flow increases with increase in pressure and increase in radius, decreases with viscosity and length. What are the applications of this equation in anesthesia?
IV lines and fluids.
Endotracheal tube.
IV line, endotracheal tube. Okay. So larger the radius of EP tube, lesser the resistance to breathing, especially spontaneous breathing in children. So in children, you must try to pass the appropriate size tube. Too smaller tube will cause more resistance. Similarly, larger the radius and shorter the length of IV cannula, then there is an increased height. With an increase in height, that will cause increase in flow. So if you want to rapidly transfuse, you have to have good height, and you should have a short cannula with a very large interior radius or diameter. What are the color coding on dimensions of various sizes of IV cannula? You are using every day in and day. What is the largest cannula that is available?
14, sir.
14.
Orange.
What is the color?
Orange color,
Orange.
290 ml per minute.
Orange color.
So orange 14 gauge, outer diameter is 2.10 millimeters, length is 45 millimeters. Then there is 16 gauge, which is medium gray, similarly same length, and white, which is 17. I don't think many of you would have seen that. Deep green is 18, pink very commonly used 20 gauge, blue 22, yellow used in pediatric, violet also used in pediatric 24 and 26. What is the possible flow rate using the different size cannula?
Orange 290, sir. 16 is 220. 18 is 90 ml.
1
Okay. So 14 is 290, 16 176, 18 76, 20 gauge 54, 22 31 ml, 24 14 ml, 26 13 ml. What is shown in this picture?
Cardiopulmonary testing.
Pulmonary
Cardiopulmonary exercise testing.
exercise testing.
Using which equipment? What is the equipment is
Treadmill.
it's a treadmill?
No, sir. Cycling.
Cycle, what cycle? The name for that cycling equipment. It is called a cycle ergometer.
Cycle.
Cardiopulmonary exercise testing using cycle ergometer is the name of it. What other physical efforts can be used to perform if you don't have the cycle ergometer? What other physical efforts can be used to perform this cardiopulmonary testing?
6 minutes walk test.
Yeah, you can do it by treadmill or by simple walking in the plains. 6-minute walk test. What is the purpose of this test? Why do you do
Assess-
this cardiopulmonary exercise test?
Assess the
cardiac
cardiac and the
pulmonary
pulmonary response
Assess
to
the
the
response of heart, lung, and what else you can assess? Musculoskeletal system. Okay, you can, it's a non-invasive way of testing the functional capacity of the heart, lung, and musculoskeletal system. How is Fick's equation important in cardiopulmonary exercise testing? What is Fick's equation and how is it important? What is Fick's equation, first of all? Idea?
card to assess the cardiac output, sir.
Fick's equation states that rest oxygen uptake is the product of cardiac output times the arterial venous oxygen difference. Okay? So VO2, it is the uptake of oxygen, is equal to cardiac output multiplied by the difference between the arterial oxygen and the venous oxygen. So how is oxygen uptake expressed? How much is 1 met?
1 met is oxygen consumption of
2.5 ml
3.5 ml of oxygen
3.5
per
ml of
kg.
oxygen
per minute.
kg body weight.
So it is expressed as oxygen per kg per minute. That is the way oxygen uptake is expressed. So 1 net is 3.5 ml per kg per minute for a 70 kg person at rest. If you say all these things, then only the answer is complete for net. It is not just 3.5 ml or 2.5 ml, that doesn't complete the answer. It is 3.5 ml per kg for a 70 kg person at rest. What two important parameters are obtained by doing the cardiopulmonary exercise testing?
Oxygen consumption and
That is VO2, peak or consumption. Then anaerobic threshold, okay? Ventilatory anaerobic threshold. So maximum oxygen consumption and ventilatory anaerobic threshold. What is ventilatory anaerobic threshold? What is the other name for this?
at a point in which oxygen demand of the muscle exceeds the ability of the cardiopulmonary system to supply oxygen.
Applied. Very good. That is. What is the other name for that? What will happen if you don't have oxygen and metabolism goes on in anaerobic condition?
Lactic acidosis.
Huh? What product will happen?
Lactate.
Lactate.
Lactate. So it is also called lactate threshold. Okay? That is defined as the point during exercise at which the individual's perfusion is to activate muscles no longer meets metabolic demand. Okay? This will result in production of lactate because of anaerobic metabolism. So this is also called as lactate threshold. What is the value of VAT? Is it the same for everybody or is it different for different people? It is different. Okay, trained athletes, they can go up to 61 to 80% of VO2 max. For normal person, 51 to 60. For mild disease, 40 to 50. In abnormal, less than 40% of VO2 max is abnormal. Okay. The patient undergoing GA develops this change in his EKG but is stable. What is seen and what would you do?
Ventricular premature
Ventricular premature complex.
Ventricular premature. Very good. Is it monomorphic or polymorphic?
polymorphic, sir.
Polymorphic, both sides. Multiple ventricular ectopics are seen. If patient is stable, just observe. It occurs in a run of 5, then needs treatment. What is the first choice? It's Lignocord 1 to 1.5 milligram IV dose. If this condition degenerates to ventricular tachycardia with a palpable pulse, then what will you do? VTAC. This ectopic suddenly become VTAC. But you are able to palpate a pulse.
Shock.
Bubble rhythm.
Assess hemodynamic status. If unstable, get ready for defibrillation. Rhythm. Okay? That is, you check the blood pressure. If blood pressure is low, get ready, even if you are feeling the pulse, get ready for defibrillation. The patient becomes unstable, what steps to be done? Of course, already I said what is to be done, but before defibrillation, we do something. Start CPR. Okay? Then defibrillate with 150 to 200 gauge shock. And you can use anti-arrhythmic drugs like amiodarone and also find out the cause. What are the types of ventricular fibrillation? Each one has a better prognosis. Fibrillation. Fibrillation, you don't say polymorphic or it can be only force or fine fibrillation. Okay, there are two types: force fibrillation and fine fibrillation. Force has a better prognosis because it is closer to normal heart activity. Okay, so if it is a fine fibrillation, you can convert it to force fibrillation. How? Find out the answer and tell me next thing. What is refractory VF?
After 3 successful shockable death.
Successful alert. After 3 shocks which are not successful, then it is called ventricular fibrillation continues after 3 successive fibrillations, not successful. Successive defibrillation. It is called a refractory VF.
Refractory.
What to do if there is evidence of acute myocardial infarction in a patient who has developed this? Under GA, first he develops an ectopic, then it becomes VTAC fibrillation, and there are evidences of acute myocardial infarction. What to do?
If it is heavy or non-STEMI, we have.
Urgent PCA may be needed if condition does not improve. You are called to see a 54-year-old lady on the ward. She is 3 days post cholecystectomy patient and has been complaining of shortness of breath. Her ABG, the values are like this: pH is 7.49, PO2 is 7.5, PCO2 is 3.9. Normal values are all given in the bracket. Bicarb is 22, base is -1. Other values are within normal range. What is the diagnosis?
Hypoxic
Hypoxic arrest.
no, sir.
Respiratory alkalosis.
Yeah, respiratory alkalosis. Low, so what do you call that? The patient is complaining of breath.
With compensation.
It shows the type 1 respiratory failure. The PO2 is low with low PO2. Respiratory alkalosis response due to patient hyperventilating to improve oxygen with high respiratory rate. Okay? So what are the differential diagnoses which can lead to this particular condition of type 1 failure?
COPD.
COPD. COPD
Sorry,
patient
sir.
CO2 should be high, not low. Chronically high CO2 இல்லையா COPD ல.
Yes, sir. Yes, sir. Sorry.
So pulmonary embolism, pneumonia, this is post-op patient. அதனால possibilities are pulmonary embolism, pneumonia, pulmonary edema, pneumothorax, asthma, or atelectasis. Okay. So how to treat this condition?
Oxygenation.
Oxygenation, but basic
Hyperventilate.
hyperventilation patient is already hyperventilating. He is in respiratory alveolar.
To increase respiratory rates, sir.
Mhm.
Yeah, respiratory rate patient is already doing. He is washing
Okay,
out the
sir.
carbon dioxide.
Oh.
So
Give positive pressure, sir.
examine the patient if acutely unwell, go for ABCD and call for help. Then individual conditions you should try to correct it. Basic problem. Take a full history and examine. Sudden onset is more likely to be PE. If it is associated with purulent cough and sputum, more likely to be pneumonia. If there is raised JVP, anti-swelling, fine basal drugs, more likely to be cardiogenic edema. Okay. So you have to go for investigations like CSR, blood investigation, culture, and the management will be if it is pulmonary embolism, heparinization, or thrombolysis. And remember, this patient is post-op, so it is a complex decision to go for thrombolysis. Pneumonia, antibiotic, asthma, salbutamol or respiratorium, pulmonary edema, and the patient sit up, reverse made and so placing the patient. Pneumothorax, you have to put an ICD. Atelectasis, incentive spirometry or chest physiotherapy. What is the difference between acidosis and acidemia? Are they both same or different?
Acidemia is in the blood level, sir.
Acidemia and the
In the blood level, sir. Acidosis in tissue level.
so now will you be able to measure the tissue level hydrogen level only in the blood, isn't it?
Yes, sir.
Many people use these two terms interchangeably without knowing the real meaning. Okay? So acidosis means it represents the underlying process causing an acid buildup in the body, which may or may not result in lowering the blood pH. You can have reduction in bicarbonate or increase in CO2, but at the time the pH may not be drifting away from the normal. Then that is called a process of acidosis, respiratory acidosis or metabolic acidosis. But if you say acidemia, that means the pH has already been affected. For example, in this case, where the pH has become alkalotic. So you have to call this as alkalemia, not alkalosis. Okay. So it is actually to be called as respiratory alkalemia because the pH has already gone beyond 7.45. On the contrary, if the pH is 7.23 or 7.3, it is acidemia, not acidosis. Okay, so indicates low pH value or alteration in the pH value. When the blood is actually acidic, it is to be called acidemia. If the process is going on without change in the blood pH, then it is called to be acidosis or alkalosis. Identify the condition here.
Left-sided pleural effusion.
Pleural effusion. Left-sided pleural effusion.
Excellent, excellent. Pleural effusion on the left. Very good.
Pulmonary edema.
Sir,
Pulmonary edema,
back
acute
pain
pulmonary
appearance.
edema. Fantastic. Very good.
The consolidation.
Consolidation where?
Right side.
Right side.
Right side. Any other diagnosis?
Pocket disease.
That's a dextrocardia. Do not forget to see the side marking here. Okay, it marked left here.
Yes, sir.
So that is the thing.
Collapse
Collapse.
right upper lobe.
Right upper lobe consolidation. Very good. What are the anatomical differences in the spinal cord between adults and children?
The spinal cord ends at the lower border of L1 in adults and children, the lower border of L3, sir.
And
Okay.
a fifth line in
What about dura?
S2, sir. Dural
Hmm.
sac ends in S2, sir.
Hmm.
In adults.
Adults. Children,
Children, yes.
little lower. Okay. Right. So spinal cords in children ends at L3 at birth and ends at L1 in adults. Dural sac ends at S3, S4 level. In children ends at S2 level. Sacral hiatus is more higher in children. It is lower in adults. Okay. What are the formulas used to determine the depth of epidural space from skin, mainly in pediatric patients? This is more of a pediatric case scenario. I mean, question. What formulas are used to determine the depth of epidural space from the skin? Okay. Rough estimate is 1 millimeter per kg body weight. Whereas another formula you can use is depth in centimeter is 1 plus 0.13 into age in years. And another formula is 0.8 plus 0.5 into weight in kg. These are all the formula that can be used. What is shown here?
Peripheral nerve stimulator.
Peripheral nerve stimulator.
So,
Do you have
with the
are you able to
epidural
see
with the epidural catheter, sir.
this is an epidural catheter. There is something like an adapter. So do you have the regular modes of stimulation here?
No, sir. It has
No, sir. This
train of
is
4 in it.
for
Train of 4 is
yes, sir.
there, but other things are all little different, isn't it? So
Yes,
it's
sir.
a for what is called SUI test. It contains a nerve stimulator, standard wire reinforced epidural catheter, and what is called the Johann adapter. What is the SUI test? Have you heard of this name before?
No, sir.
Yes.
It's a Japanese fellow who devised this to locate the correct position of epidural catheter by epidural stimulation. So what he did was, during the test, an electric current is conducted through the column of saline, which is going through a standard wire reinforced catheter. The advantage and disadvantage of this technique is the epidural stimulator test provides valuable objective information that aids in the assessment of catheter placement. The disadvantage of the epidural stimulation technique is that it cannot reliably be performed if any significant clinical neuromuscular block is already present or if local anesthetic has been already given in the epidural space. How is the location of the catheter made out by this equipment? Is a continuation of the same question. So if the catheter is subcutaneous, no motor response will be there, even if the current is more than 10 milliamperes. If it is subdural, the catheter has migrated into subdural space, then even a low current as 1 milliampere will cause bilateral motor response. If it is subarachnoid, may cause unilateral or bilateral with less than 1 milliampere current. If it is correctly placed in the epidural space, against nerve root. If it is hinging against a nerve root, you will have a unilateral response with less than 1 milliampere. If it is non-intravascular, you may have unilateral or bilateral with the current of 1 to 10 milliampere threshold, increasing after LA injection. If it is intravascular, you will have no change in the threshold after LA injection. Okay, whereas it will reflect to that correct place. I am showing here two ultrasound images.
First
What are
one is
shown?
caudal
Ah.
ultrasound, sir.
Second one is
Second is also look like a caudal ossified, probably adult, sir.
both are different axes. Okay, use image of short axis view of the sacral conva and the sacrococcygeal membrane is the top one. Okay, this is the long axis view to show the caudal epidural space, full space. Okay, so these are the views: short axis view and long axis view. What is shown here?
Pediatric
Pediatric
intrathecal
spinal
injection.
Very good, excellent. Equipment used for spinal anesthesia and neonates, spinal needle and syringe with local anesthetic. Excellent. What is the dose of LA drug for spinal anesthesia in children? How do you calculate the dose for intrathecal injection in child?
Armitage formula for
Armitage is for
Caudal
epidural caudal block and the epidural
0.2 ml per.
So age in months, up to 4 months only what you require. For weight 3 kg, you can give bupivacaine 1 milligram per kg. Then at age 2 months, weight 4 kg, 0.8 milligram. As the age and weight increases, the dose will decrease. So lower the age and weight, you can go up to 1 milligram, then you reduce it to 0.8, 0.6 and 0.4. What are the contraindications for spinal injury?
Spinal bypass.
Abnormality.
Anatomical malformations.
There are so many anatomical abnormalities, degenerative neuromuscular diseases, patient and family descent, coagulopathy, bacterial infection, raised intracranial pressure, peritoneal shunts. What is shown here and what precautions to be followed in this position? What technique you would do for adults? Is the sitting position for spinal anesthesia in a child, just like you do in adult. But only thing, somebody has to hold the baby because they cannot sit on their own. Okay. But what is the precaution to be followed? Looking at the picture, you just tell me.
So neck instability.
Head flexion must be avoided to prevent airway obstruction. Okay. That is the main important thing that has to be done. What is seen in these pictures?
Cardiopulmonary resuscitation in pregnant
woman. What is the lower picture?
Lateralization of the uterus.
You are pushing top one shows CPR done by 3 rescuers. You must describe all the things in the picture. One doing advanced airway management, second one performing cardiac compression, and the third one doing left uterine displacement. So 3 people are here. The bottom one shows double-handed left uterine displacement. A person using both hands to displace the uterus. What are the modifications done during CPR in pregnant patients?
No need to monitor the heart rate, sir.
Try to maintain supine position for effective compression, but do manual left uterine displacement unless doing CPR by single rescuer when left lateral tooth can be given. That is number 1. Anything else? and slightly higher on the sternum. Should not be very low because there will be gravid uterus pushing the heart upward. Quick compressions, early intubation, remove cardiotopographic leads before defibrillation. Plan for perimortem cesarean delivery if CPR is not successful. How is perimortem cesarean done? And what is the other name for it?
So it is done if spontaneous circulation has not returned after 5 minutes of resuscitation.
No, I'm not asking when it is done. I'm asking how is it done.
Classical
On-table,
cesarean section,
it is
sir.
done at the
On table,
At
same,
the site
place
same
of
area where the
cardiac
CPR is
arrest.
going on, sir.
It is done to save the mother's life when CPR are not able to achieve return of spontaneous circulation. It is to be decided within 3 to 4 minutes of cardiac arrest, and it is aimed to open abdomen rapidly, deliver the fetus quickly, and close the abdomen fast to remove the aortocameral compression. That is the main idea of that. So no need to paint and drape. Vertical incision, both abdomen wall and uterus, deliver the baby and close by a single layer closure. What is the other name for it? It's also called resuscitation. Continue during this phase. This is called resuscitative cesarean section delivery. Okay? Post perimortem, also called resuscitative cesarean section delivery. 40. Just one more, I will stop here. What is shown here and how does it work?
Sir, MRI.
MRI
An
should
MRI, very good. What is this? An MRI machine. How does it work? It produces a strong
Electromagnetic
field
field.
and the hydrogen atoms of water become aligned either in the same or in the opposite direction as the magnetic field. The pulse of electromagnetic radiation directed towards the body causes the hydrogen nuclei to rotate from their equilibrium. And when this radiation is removed, the nuclei emit radio waves as they return to original equilibrium position. So the radio wave signal is detected by the coil in the scanner and is processed by computer to produce a visual display. What are the components of an MRI scanner? You can see some of the things: radiant coil, radio frequency coil, magnet. So the primary magnet, gradient magnet, radio frequency coil, and computer system. These are the 4 components of that. What are the features of primary magnet? It's a coil of wire made out of superconducting material through which current is passed. This material has no resistance below minus 260 degrees. It so can produce a very large magnetic field. To achieve this, the temperature, the wire is kept in liquid nitrogen and helium. Okay, that is how the very low temperature is achieved. What is Tesla?
SI unit.
SI unit. It is the magnetic flux. Okay, it is the magnetic flux density called Tesla. It is the power of that machine. 1.5 Tesla, 3 Tesla. So in some of the MRI people will advertise, we have 3 Tesla machine, which will be more accurate than 1.5 Tesla. So magnetic flux density. The other unit of measuring this is called Gauss, and the equation 1 Tesla is equal to 10,000 Gauss. And you have a 50 Gauss line in the MRI shoot. Have anyone of you gone and seen what is the 50 Gauss line? That is the minimum distance beyond which you cannot go near the, or any electromagnetic substances should not go near that. What is meant by T1 and T2 weighted images? All of you MRI report லாம் படிச்சு பார்த்திருக்கீங்களா? They would have
Yes.
given T1 weighted T2. So it
Yes,
is the
sir.
relaxation time constant. T means the relaxation time constant. They measure how the nuclei relax back to their original position. And the main difference, how to identify whether it is a T1 weighted image or a T2 weighted image is fluid looks dark in T1, fluid will look white in T2. So if you take a brain MRI, if the CSF looks dark, black, the other tissues look white, it is T1. If the CSF with the ventricles look white, it is T2 weighted image. Okay, that is the, sometimes the exam they may ask you that and keep pictures and asking that. So I will stop here.
Yes, sir.
Thank you. We will go